Hi, everyone, and welcome to the SRHM Podcast, which explores new research and emerging trends in the field of sexual and reproductive health and rights, with a focus on using rights-based knowledge for action.
Hello for everyone. I'm Eszter Kismődi, Chief Executive of Sexual and Reproductive Health Matters. In today's episode of our podcast, I'm pleased to introduce Sarah Malaba, the Co-Chief Executive Officer of Tiko, an African nonprofit organization partnering with governments, health providers, and local community-based organizations to reimagine healthcare systems for adolescent girls across Sub-Saharan Africa. Welcome to the conversation, Sarah. Thank you so much for being here.
Thank you for having me on behalf of all the girls in Africa.
Sarah, we are recording this conversation after a very exciting blog that we just published with you called Unlocking the Girl Dividend: Why Smarter Health Financing is Africa's Best Economic Bet. We are just after the 9th RHNK Pan-African Adolescent and Youth Sexual and Reproductive Scientific Conference in Mombasa. I'm coming out of the World Health Assembly in Geneva, and the conversations very much were preoccupied about the World Health Summit in Nairobi's agenda around health sovereignty, integration of care, domestic financing. And the conversation with you is really focusing on what's happening, how it's impacting the girls in Africa. And in your view, and based on what you are doing with Tiko, how this agenda is actually reaching the girls who need it most, and what this health sovereignty exactly means from this perspective.
Thank you so much. That's a really good question. And I was part of the World Health Summit that was in Nairobi, and I was part of the RHNK conference. And one of the things that stuck out for me is that the RHNK team did their best to make sure that young people were in the room and were actively providing their thoughts and recommendations around this subject. What was really profound for me is that young people were saying, these conversations are too high level. They need to be practical. We need to move from the concepts to showing them the how. And for them, the how that was so important to them was to say, can the health systems be refashioned to mirror what our lived experiences look like? And can the health services be fashioned to mirror their current realities around their life cycle and what actually is going on with them? So I felt coming out of RHNK that indeed, when people talk about the girl dividend, sovereign funding, financing for girls' health, the person who this subject needs to touch the most is still feeling left out and left behind. And for me, the big takeaways were we need to refashion the health service delivery itself, and then we need to refashion the financing for it. So if we don't do the two in tandem, then we will not actually touch the day-to-day girl who these issues that we talk about around the triple threat impact the most.
Can you actually talk, Sarah, about the triple threat? What does it mean and how it fits into the siloed system, and who actually has the power, accountability, responsibility to break that open, and what's stopping not doing that?
Yeah, so the triple threat, in as far as Tiko is concerned, and most of the African governments, when you talk about the triple threat to the lives of girls, it talks about the three interconnected but dangerous threats that collectively account for the highest number of disease, the highest number of deaths, and the highest number of disability among adolescent girls and young women in Sub-Saharan Africa. And the three really around unintended pregnancy, new HIV infections, and sexual violence. So those three in the past, in terms of addressing them, were addressed in a silo because that's how funding and the health structuring was done in terms of services delivery. But today we say that if we're to win the war against unintended pregnancy, which continues to persist, and more than 3/4 of new HIV infections take place among adolescent girls of 15 to 24 years, we need to actually address the pervasive issue around sexual violence, which is really the biggest driver of unintended pregnancy and HIV. In that sense, then, they cannot be addressed in a silo. They need to be addressed collectively. So first, I think there's a realization that if we were to change the health landscape of adolescent girls and get them to adulthood thriving, we must address the triple threat collectively and in an integrated manner. So that's a high priority per what the data shows us and the impact around the adolescent health. Now, talking about the issues and barriers around this, from the perspective of Tiko, awareness is a big barrier. If we don't address awareness, the fact that adolescent girls need to understand these issues, starting from their reproductive health, the choices that are allowable for them, the health services that they need, and where to find them, we are still going to fail. The second one is really an access issue. And access here talks about young people always articulate the way they feel stigmatized and discriminated because these subjects around these three areas really touch on the core of their lives, which is their sexuality. Sexuality is still a difficult conversation to have, even with a healthcare provider, who sometimes will be asking why a young person is already sexually active, why they believe they put themselves in harm's way to experience a rape. So young people feel like they're judged, they're stigmatized, they're discriminated, and the services are not youth-friendly. Besides that, we know that there are health clinics in Africa. It's not that they are not there. We also know that there are community health workers who are busy doing promotive health. But the issue is that those systems are not fashioned to work for adolescent girls. They are fashioned around curative services. Everything I'm talking about here needs to be looked at from the preventative side of view. And if we don't do that, then access continues to be a barrier for the young people. The last one is really the issue of affordability. As much as I've mentioned these things, contraceptive care practitioners agreed that should be a free service, open to all women and girls across the globe. HIV is also a rights issue in terms of accessing critical services, whether those are testing services, preventative or treatment services. And when you talk about sexual violence, this is where we can really go hard around the human right for girls to be safe in the environments where they live. But really, when you look at it, some of these critical services are not free and certainly not for the most vulnerable of the girls. So here I'm not talking about a girl in a middle income or higher income family. I'm really talking about that girl who couldn't even afford what sometimes we believe are very minimal user fees. Any form of user fees in the health system kicks out the most vulnerable of the girls. So the leading causes of this, in our view, why this triple threat persists, is really around awareness, access, and affordability. I know other people could talk about other things, and so I believe, and we know, that the duty bearer when it comes to health is really the government. But we can expound a little bit on how a multi-stakeholder approach is needed when we're talking about the triple threat.
Absolutely. And you mentioned at your earlier point the girl dividend. And when we come to health financing and health sovereignty, there is an economic case. But as you mentioned, there is also, it's not only about economic argument, it's also a human rights commitment and the development commitment, and there is a human element. So how do you bring together the economic case, the girl dividend? What does it mean exactly? And can you talk more about how health sovereignty can be positioned in the context of accountability?
Yeah, this is one of my most favorite subjects in the recent times, because I think it's an easy one, but we need to make sure that it is staged correctly. Everyone says that adolescent girls, especially in Sub-Saharan Africa, are the biggest opportunity we have because the continent is the youngest. But the issue is We cannot just stay on that hope that, we have the youngest population. If we allow the triple threat to persist for this girl, they are not going to stay in school, for example, because unintended pregnancy is a leading cause of the reason why girls are not in school, right? If we don't address the triple threat and girls drop out of school, it means lower economic earning power. It actually means that instead of reaping a dividend, we will reap the opposite of it if these girls don't get to adulthood thriving. If girls in their communities cannot be safe from gender-based violence and rape persists, and then we talk about even just the mental trauma that comes with it, they cannot live to their full potential. So when we talk about the triple threat, the young population in Africa, we're saying we need to invest in that population so that it gets to adulthood thriving. And only then we will reap the economic benefits that this girl dividend, this young population is going to afford Sub-Saharan Africa. And that is why investing in the triple threat is not just a health argument. It is saying that investing in the triple threat will keep girls in school, will make girls not become child brides, will help girls to have a higher chance of better earning power, more gainful jobs, and more meaningful pay for them. Mm-hmm. From the public health perspective, we know what it means to have an educated woman. It means delays in childbirth and choice around that. It means better birth spacing should they choose to have a child. It also means better job placement. And if they're a mother, everything about vaccination that we know, for example, that children will be vaccinated for sure. So we see data from the Critical World Bank reports that talks about the future economic returns and the unlock that we get, and really quotes a figure around every dollar invested in girls' empowerment yields a tenfold return. And with that, we potentially add 2.4 trillion to the African economies by 2040. But there is no way of getting there if we don't address the triple threat, which will help us to get these young girls to adulthood thriving.
So as I understand, Sarah, then so it's very clear that there has to be a breakout of donor dependency, but also means that governments have to take genuine ownership and earmarking domestic funding to girls' health. So it's not only just adding girls into the maternal health agenda, adding girls to the HIV agenda, adding girls into the GBV agenda, but there has to be a clear line of health financing that actually goes beyond health financing. It also includes social accountability in so many perspectives. So what can move action? So how the actual financing into girls can happen in take your own government, or what do you think needs to happen?
Yeah, so maybe even before I get there is to say, just to double down on what you have said. If we're to reap the girl dividend, the government as a duty bearer needs to take responsibility, because this is about the economic future of their own countries. We cannot cede that out to other governments or other players. And so it's actually a matter of saying, governments, put your money on your biggest opportunity. If the girls are your biggest opportunity, the money needs to match what you're prioritizing. And now it is time to actually prioritize girls as a standalone group, disaggregated group, not aggregated with women or other population or other diseases, but really delineate what it will take to keep girls healthy, to keep girls in school, to keep girls in jobs, right? To keep girls safe in the countries where they live. It's a multi-sectoral and a multi-issue that we need to put ourselves together. It's also multi-partnerships that are required here. So one of the things that I began to see with the RHNK conference is that a woman that I really respect, Dr. Onikpe, who works for the Guttmacher Institute, began to show data that was very clear and explicit around what it will take to reduce unintended pregnancy and new HIV infections for girls globally. She had global disaggregation. And she actually even put data around how much extra investment is needed. In some of those circumstances, it was $1.98 that was needed to actually do a dramatic shift around this subject of unintended pregnancy and new HIV infections. She and I agreed that we need to work together to layer on the sexual gender-based violence data so that it can really talk to the triple threat. But so if we have these kinds of data, Tiko and other partners are realizing that we need to support the government to actually now turn policy into action. If the understanding is that sovereign funds and sovereign investments are needed for girls, we as partners need to show A, where the highest impact is, B, how much that impact costs, and C, delivery models that work. All right. Mm-hmm. And I believe that these three things is what now government needs to turn these big statements around sovereign funding and the girl dividends into action that will enable us to move and now actually begin to reach the girl on time. Because the girls' needs are not going to wait as we argue and as we fashion beautiful concepts. Today, there are girls who are going to get pregnant because of lack of a contraception. Today, there will be new HIV infection. Today, countries are rolling out the life-changing injectable pre-exposure prophylaxis, and girls need access now. So we need to invest starting today.
And to make this turn, you emphasize that it's a policy choice. So how do you see that this policy choice happens? It cannot take years. It has to happen immediately. So how do you see that this policy action actually will happen?
From where I sit, I can talk about the way Tiko has been trying to work with governments to make this practical. What we try to do is begin to break down what the population of girls look like at national and subnational level and start with the most vulnerable girls. Because even when we talk about funding, I know that that basket is not to infinity, right? There's any X amount of funds. And I'm saying, can we start with the most vulnerable girls? And those could be girls already sexually active, girls who've already dropped out of school because of pregnancy, girls already facing a sexual violence with no chance of reconnecting back to school or to their livelihoods because they have a mental health breakdown and trauma that needs to be addressed today. So if we begin with quantifying who are these vulnerable girls, sometimes also based on multidimensional poverty indexes, because poverty is an issue here, the girl who is likely to experience the triple threat is also one that lives in the most needy situations. Sometimes for Tiko, it's the informal settlements within urban and peri-urban areas. So we support governments to think about who is this girl, classify them, who is the most vulnerable, who is left out, and then begin to think about how much is needed from a delivery point of view. For instance, if you have 200,000 girls in your district classified as most vulnerable, we need to begin to think about what and how much commodities is needed when it comes to contraceptive care. Where are the service delivery units and what modality would work for them? How do we get them to be informed about these services and begin active referrals into service uptake? How do we support our healthcare providers so they can truly provide stigma-free, girl-centric, integrated, high-quality services for those adolescent girls? Now, when we quantify that, for me, it's a matter of government, A, committing to commodities, B, committing to public sector staffing that will not be interrupted by industrial strikes or understaffing. 3, committing to quality assurance systems that begin to get the girls' voices around their satisfaction. And if they can refer their friends to these services, because that will be a first sign that the services are youth-friendly and girl-centric, and so they can actually come in. Because it's one thing to have a beautiful facility and healthcare providers, and a totally different one for girls to come in because they feel safe and understood and guided and empowered to take the decisions that they take. And then lastly, we'll talk about how do we track the impact so that we can link demand to supply, but also understand where the system continues to fail girls. So this is how I think we can do it, make the problem manageable, make it fundable, and change the system and begin to link awareness to service uptake.
We were chatting about it before the conversation that both you and me worried about, that how the concept of health sovereignty actually plays out. It's a very legitimate concept, but what happens with accountability when in a certain setting all aspects or most of the aspects of girls' sexual and reproductive health and rights is criminalized, highly restricted, under 18 sex, abortion, sexuality, comprehensive sexuality education is not there, then how this sovereignty works out in the and what we need to do to make it clear that it doesn't mean that you can just run off and do whatever you want, dear government.
Yeah, I think the whole concept around health sovereignty and the funding that comes with it needs to practically address what I will call girl centricity. If governments are girl centric, they meet the young girls and young people where they are in the circumstances that they are in and hear their voices around what is breaking for them in health service delivery. The governments begin to untie the healthcare workers' hands where there are policy restrictions. The government begins to understand and empathize and fund for awareness that is correct, that will support the adolescents to understand, to be empowered, to have agency and exercise it. So if sovereignty means sometimes what people in the sector just say, we are going to integrate, there's going to be a government transition, we're going to lose it. It's not as simple as those two concepts. And sometimes those two concepts actually mean that either that disease or population will fall through because no one is going to give accountability around the who is behind those numbers and where they are and if actually they have access. So for me, health sovereignty means, if it is true, we believe that young people are the dividend for our countries. In whatever fashion they show up, we need to provide services for them. And then, coupled with that, I know when you talk about adolescents, really, if governments don't think about this population as a legacy issue, they will fund for the short term. We always need to remember, every new year, there are young people being born or young people turning 15 or becoming adolescents, and we need to program for them. So it's a long game we're playing here. So financing needs to be a long game. It also means that governments need to begin to think about blended financing tools and funding for outcomes, not activities, not processes. We need to be putting money where the outcomes are. Outcomes that help us reduce teen pregnancy or unintended pregnancy, HIV and sexual violence, where we should be funding, not workshops, not activities, not visits. No, we actually need to fund for service delivery, service access for those adolescents. And if in the interim we will need additional philanthropic funding, but starting off with government investments, and then build out a long-term view of what that legacy sovereign funding needs to look like, then I think we're going to start winning and being practical rather than just putting words and concepts around.
And my last question is linking back to your first point that you come out of the RHNK conference, there was a high youth participation, including girls. So where do you see the participation and the role of the girls to participate of the making this policy choice by the government and implementing it? And how Tiko girls work with girls on that?
Yeah, I think a very important point is to always make sure that in the rooms where policymakers are, girls can become more visible. We need to stop having government just look at numbers and say there's 1 million vulnerable girls. We want to begin to bring those girls into those rooms because government putting a face to the person, to the number that they have, and hearing their stories around what barriers stop them from coming in is going to be important. And that way, adolescent girls become part of the design, really actively saying, this is what is going to work for us, this doesn't work for us. The second thing is that as we deliver services, absolutely continue to understand what's changing with them. I keep emphasizing adolescent girls are not homogeneous, but the way sometimes we write our policies, we believe from Burkina Faso to South Africa, they look the same. They are not. And I even challenge ourselves to say a girl who turned 15 today compared to a girl who turned 15 in January have very different practices. But what will help us to implement in a way that meets their needs is constantly, as we deliver, getting feedback from them. What's working? Are you cancelled properly? Did you get your commodity? Is the clinic too far? Is it too near? Who is the best source of information for you? Which nurse do you prefer? What is integration to you? What makes you discontinue service uptake? And so on and so forth. Because girls need support to make sure they are not ones that need to figure out how to navigate the health system. We need to make it seamless for them. And then lastly, we need to be looking at data actively. Again, those issues I mentioned, they don't need old data. Even 2 weeks is too late. Imagine if a girl has experienced rape the last 72 hours. If you're looking at dashboards and data more than 72 hours from now, you will miss out on who needed critical services to absolutely prevent a new pregnancy, a new HIV infection, a new STI, because they showed up 72 hours earlier, but the clinic was closed. So real-time data is going to be a game changer. And especially when we wrap it with the girls' real-time voices, it's going to help us to unlock the quagmire around service delivery for adolescent girls.
Thank you so much, Sarah, for being here with us today. And I'm really looking forward to continue this discussion. Thank you very much. And I encourage our listeners to also visit our blog page, read the blog, and visit also Tiko's work on the website. We have the link on our SRHM blog and in the podcast. Thank you very much, Sarah.
Thank you for having me. Let's do this for the girls.
Let's do it together.
Thanks for joining us for this insightful conversation. Please check the show notes for a link to the SRHM Journal, which is available online and open access. Follow us on social media and sign up for our newsletter to receive notifications for new publications. If you're enjoying this podcast, please subscribe, give us a rating, or leave a review. Sharing evidence-based and rights-grounded knowledge is our passion, and it's also critical to support the advocacy and actions that need to be taken to improve SRHR for all. We would very much appreciate it. Thank you for supporting the SRHM Podcast, which is produced by our staff. The music was composed by Tiber Christian and Salomon Beautond.